The shoulder is a spheroidal multiaxial joint stabilized not only by its bony anatomy, but also by the surrounding muscles and capsular structures. Black square arthroscopy is the process of visualization and examination of a joint using a fiberoptic instrument. All shoulder surgeons must be proficient in diagnostic arthroscopy of the shoulder. The glenohumeral joint consists of the glenoid fossa of the scapula that articulates with the head of the humerus. Black square. The labrum is a bumper of fibrocartilaginous tissue around the rim of the glenoid that acts to deepen and enlarge the glenoid fossa and increase glenohumeral stability. The biceps tendon is anchored at the superior labrum and acts as a humeral head depressor and also aids in glenohumeral stability. Black square. The static stabilizers of the shoulder include the joint cap, capsule, and the glenohumeral ligaments, superior, middle, and inferior glenohumeral ligaments. These will be discussed in greater detail in subsequent chapters. Black square. The dynamic stabilizers of the shoulder are the rotator cuff muscles, supraspinatus, infraspinatus, subscapularis, and teres minor. Black square. The scapular stabilizers, rhomboids, levator scapulae, trapezius, and serratus anterior, also contribute to dynamic stability of the shoulder. The most important part of the physical examination consists of taking an accurate history from the patient. Black square. Was it a traumatic, non-traumatic, or overuse injury? Black square. When and how did the injury occur? Is the patient's complaint of pain, loss of motion, weakness, or inability to perform sports, activities of daily living, or work? Black square. Is there pain at rest, only with activity, or while sleeping? Black square. Are there any neurologic symptoms? Black square. Basic physical examination methods are summarized below. More specific examinations for different diagnoses will be described in other chapters in this section. Black square. Observation of patient with shoulder pain from the front, back, and side. Black square. Identify any muscle atrophy and asymmetry of muscles, shoulder height, or scapular position. Black square. Palpation of different parts of shoulder, sternoclavicular joint, acromioclavicular joint, greater tuberosity, and rotator cuff, glenohumeral joint, biceps tendon, trapezium, too low. Localize any areas of point tenderness, which may aid in differential diagnosis. Black square. Passive and active range of motion, forward flexion, abduction, adduction, internal and external rotation. Black square. Loss of range of motion may indicate adhesive capsuli, tis, rotator cuff pathology, tendinitis or rotator cuff tear, or degenerative changes. Black square. Resistive testing of deltoid, supraspinatus, infraspinatus, and subscapularis. Black square. Weakness of any muscles may indicate nerve injury, torn muscle or tendon, or weakness secondary to pain. Black square. Rotator cuff and scapular stabilizers. Look for atrophy, scapular winging, weakness with strength testing, and painful range of motion. Black square. Provocative tests for rotator cuff tear include drop arm sign and liftoff or belly press for subscapularis. Black square. Impingement tests include the Neer and Hawkins tests. Black square. Labrum, catching, clicking, popping may indicate a labral tear. Check for instability with provocative tests, load shift apprehension test or crank test, relocation, O'Brien's. Black square. Multidirectional instability. Look for increased laxity in ferry, orally, and in one other direction. Black square. The sulcus sign demonstrates inferior laxity. Black square check for the ability to voluntarily subluxate or dislocate the humeral head. Black square acromioclavicular joint, localized tenderness over the acromioclavicular joint and pain with cross-chest adduction. And O'Brien's testing plane radiographs are used to assess different aspects of the shoulder joint. Black square basic radiographs should consist of anteroposterior, axial, Larry and outlet views. Black square special views may be obtained depending on shoulder pathology and will be discussed in subsequent chapters. Magnetic resonance imaging, MRI, and MRI arthrograms are also commonly obtained to aid in diagnosis because they are highly sensitive and specific in diagnosing many shoulder injuries. Differential diagnosis. Black square impingement, internal or external. Black square rotator cuff tear. Black square adhesive capsulitis. Black square acromioclavicular joint injury or arthritis. Black square labral tear. Black square instability. Black square biceps tendon pathology. Black square degenerative arthritis. Black square scapulothoracic dysfunction. Black square cervical or neurologic. Black square infection. Non-operative management for many different diagnoses may first consist of rest, non-steroidal anti-inflammatories, physical therapy, and diagnostic and therapeutic injections. A patient who has failed to respond to non-operative management and continues to have symptoms consistent with his or her diagnosis is a candidate for shoulder arthroscopy. Preoperative planning. Black square patient history and imaging studies are reviewed. Black square, the surgeon should have a good understanding of what pathology to expect at the time of arthroscopy to ensure that all appropriate equipment and instruments are available. Black square patient positioning aids, arm holders, weights, beanbag. Axillary roll. Black square arthroscopic pumps or irrigation system. Black square video monitor, 30 and 70 degree arthroscopes. Black square arthroscopic cannulas. Black square shavers, burrs, suture anchors, arthroscopic instruments. Probe, grasper scissor basket. Black square an examination under anesthesia is performed to assess range of motion and stability. Positioning. Black square shoulder arthroscopy may be performed with the patient in either a beach chair position or the lateral decubitus position. A Fig 1. Black square the beach chair position requires a specially designed aiding table attachment that ensures that the surgeon has adequate exposure to the patient's posterior shoulder and the patient's head is well supported. Black square the advantage of this position is that the shoulder can be freely manipulated throughout the procedure. Black square commercially available arm holders can also be used to allow glenohumeral distraction and positioning without the need for an assistant. Black square when used